Hi. So I'm one of you, and I wanted to introduce Bob Rohret and Shar Lopez. Bob is the Director of Health and Human Services for St. Croix County, and Shar is the Deputy Director of Health and Human Services. Bob has a long career. He started out as a social worker and has been in Hawaii and Iowa, and has practiced best practices everywhere he goes, and we are so lucky that he's come to St. Croix County to show us the newest and best ways to do things, and a wonderful person and administrator. Shar has a background as a counselor in mental health and now in administration. She's worked in prisons, and what we really need is what she brings to the table, and we're very lucky that she's here. So with that, I'd like to invite them to come and share their knowledge with us.
Thank you. I'll find a place for my coffee. Right next to the electronics. What could go wrong? No, I'll set it down. I don't trust myself. Well, thank you. Thank you, Supervisor Hanson, for the kind introduction and for inviting us tonight to talk a little bit about mental health and addiction in St. Croix County. And I brought Shar along because she understands all of this in great detail and has prepared a nice presentation that I hope addresses some of the interests that you have and answers your questions, or we can certainly try and answer any other questions you might have. I think for my part tonight, what I had planned to talk about a little bit was a couple of broader laws and national and some state issues that affect the way we provide behavioral health care in Wisconsin. One is the issue of institutions for mental disease. It's an exclusion under Medicaid law that was created in 1965. And the other issue is what is the other issue? Help me. I'm sorry. I was traumatized right before coming here because I was at a 7th grade volleyball game. It's Medicaid expansion is what I wanted to talk about just a little bit. So if I could do that and just sort of lay a broad opinion from a professional point of view, thank you, about both of those topics, Medicaid expansion and the IMD exclusion under Medicaid. It might lay some of the foundation for the things that Shar talks about and some of the difficulties we have adapting our system of care to what we know would work best and have the best outcomes. So I'll be kind of brief because Shar has good information for you, and I don't want to take up too much time. But the issue of Medicaid expansion comes up in every budget cycle, at least the last 2 biennium budget cycles, where Wisconsin is one of a handful of states that has not agreed to participate in Medicaid expansion. What Medicaid expansion does, would do for us as a state and a county, is increase the eligibility for Medicaid to a population now that's really considered the working poor, who make too much to receive Medicaid and don't make enough to afford private insurance. These folks still get health care, they just get it in the form of emergency care, which the hospital then pays for, passes that on to the health plans, who pass it on to us as taxpayers. So what Medicaid expansion does is it expands the eligibility for Medicaid so that people who are lower income, maybe working, maybe not, but don't have access to health care, don't have access to health insurance, would be eligible up to 133% of poverty, I think is the cutoff there, for health insurance. The more people we insure with health insurance, the lower the cost overall for health insurance, because these folks are getting preventive care, they're getting routine visits at their doctor's office, et cetera, and they're not waiting until they get very sick or something happens to go get health care at the emergency department. That's one benefit of Medicaid expansion. The other is an economic benefit. When you look at the federal share of Medicaid dollars through expansion, states pay about 10% of the federal funding. So Wisconsin would pay about 10%, and that was even incentivized further at the last state budget to only 5%, but we still didn't vote for it. But it brings dollars into our state that, even in the form of health care, where people are using health care providers that they otherwise wouldn't, they're having, then they have disposable income to use on other things like rent and food and, maybe some, if they're lucky, maybe some recreational kinds of things. But every year, when Medicaid expansion shows up in the governor's budget, it's automatically dismissed at the legislature. And I've had these discussions with legislators and asked, what is your resistance to this? Every other state in the union, with the exception of a handful, have agreed to take part in Medicaid expansion. And it would bring money into the system that would then allow us as a county to provide services that we can't right now and have a reimbursable way of doing that, and expand a lot of what we do right now and get a rate that covers most of the cost. And a lot of the reaction is very emotional. It's not so much factual. So a lot of the reactions I get from legislators around this topic is we don't trust that the federal government will keep their end of the bargain and pay us as a state. And the federal government hasn't defaulted on any of these agreements with other states in the 12 years that the ACA, the Affordable Care Act, has been in place. So there's no indication that that's going to happen. And the other resistance that I hear to this is that, well, states still have to pay 10% of the overall funding, a match of 10%. Yes, but we lower the healthcare costs overall for the state, which saves us in the long run more than 10%, and we end up with a positive balance sheet at the end of the day, or at least the other states who have done this have shown that that's the case. You provide better healthcare to more people, and you lower healthcare costs, and that's the reason I bring this up, because without Wisconsin being a Medicaid expansion state, it limits some of the options that we know, Shar and I know, would be helpful to our county to provide to our residents, especially our lower income residents. I bring that up because I'm not trying to lobby here, but at the legislature, there isn't a lot of support for this, even from other counties where they don't see this as a major issue, and I do. So it's just something to think about. But the other topic of the IMD exclusion, institutions for mental disease, like I said, that's part of the 1965 Medicaid law, Medicare law, that limits Medicaid payments to facilities with 15 or less beds. The idea behind this was to deinstitutionalize the mental health care system by limiting large institutions from receiving Medicaid payment and instead moving those services out to communities, community-based care and smaller community-based care settings, which is a good idea. I don't disagree with the concept. But the IMD exclusion also applies to addiction treatment, which is a short-term stay. And what this law intended to do was to prevent long-term stays in mental health institutions and instead treat people in their communities and try and get them reintegrated into their communities, which is good, right? But the law specifies addiction care as a component of the IMD exclusion. So if you have an addiction care facility with more than 15 beds, they're not eligible for Medicaid reimbursement. That's not true? No. Okay. Yeah, so this was a huge issue in Minnesota. When I worked in Minnesota, we recognized this was limiting the number of providers, especially in the addiction care world, who could accept Medicaid and expand their services and help more people, and clients that could then have a reimbursement stream for that. And what Minnesota did, being a Medicaid expansion state, was they had to go through a process of, it's a waiver, a federal waiver they had to get, but it required them to redesign their entire behavioral health system in Minnesota. They had to have this written into their state plan. It took a lot of work, but we did that. Medicaid, or CMS, the Centers for Medicare and Medicaid, accepted our plan, and we were able to transition people from either private pay or sliding fee scales to a Medicaid-based healthcare system. And it expanded, in many ways, it expanded our options for how to provide this care, not just addiction, but other kinds of case management and community-based care. And again, transitioned away from this, this notion of fighting with your private insurance company to pay for or not pay for addiction care. There's also a federal parity law that requires health insurance to pay for behavioral health care in parity with physical health care, but nobody enforces it. So the law's there, but there's no enforcement of it. And there's an effort, I'm sorry I'm talking so much, but I was a part of an effort with Patrick Kennedy when I was with Minnesota that was looking at trying to strengthen parity laws so that states were required to pay behavioral health care reimbursement at a comparable rate as physical health care. And it's a worthwhile effort, but it meets with a lot of resistance from lawmakers because of the cost involved. Anyway, the IMD exclusion is something that costs us as a county and taxpayers, I don't know how much, $1 million maybe last year in placements at IMD settings because they're the only place where we can find a bed at that level of care for our clients that have no insurance. Or even if they have Medicaid, it won't pay for it. So we end up, this is where the sheriff comes in, and Shar will talk about this, but we end up in a system where law enforcement's transporting people with mental health conditions, severe mental health conditions, and or addiction disorders, transporting them to Winnebago in a squad car in handcuffs to go to a facility that there's no payment source for other than taxpayer dollars. Now, I'm not criticizing Winnebago's care. I'm just saying there are no local options because we don't have a system which supports that financially through switching to a Medicaid-based payment source for lower income folks. And because of that, then there's no opportunity for growth or for providers to take the risk of starting a facility and wondering if they're going to be in business. The way DHS has managed this to date, at least in my time with Wisconsin, is to put out grants for startup of these kinds of facilities, but there's no sustainability plan beyond that because there's no, again, standard reimbursement mechanism to support them. So we struggled with this at St. Croix County, and we actually came up with a plan to open a medically monitored withdrawal management service here in St. Croix County that would take people with addiction disorders and mental health disorders who the police could just drop off at the center. We would treat them with medical staff and with behavioral health staff and then connect them back into the community or wherever they wanted to go. And there was a grant for that. We applied for it, and even though we proposed the idea to the state, we weren't funded. So that leaves us back to square one, whereas a state where they're still looking for these regional urgent care centers for behavioral health, looking for someone to start them up, but the sustainability's in question. The workforce is such that it's very difficult to find people to work in those environments, and it leaves us struggling to figure out this problem. So I kind of went off track about institutions for mental disease, but that's a law in Medicaid that has been debated for decades now about its merits because it limits the number of inpatient beds that are available to us for these clients who need them. I'm not a person that believes in building more beds to solve a problem. I don't think that's the answer. But I think a coherent and well-funded system at a community level is an option that we should pursue and that would lead to better outcomes for people. Otherwise, they're cycling through emergency departments and jails and crisis services like the ones that Shar will talk about. And that's not a good system of care for anything, and it's certainly not in parity with physical health care. So those are the two issues that really, for me as a director, come to mind whenever I'm having legislative discussions, and they sort of are overarching for other things that we would like to do. So I encourage you, I guess, to speak with your legislators about these topics, primarily the Medicaid expansion, learn more about it yourself if you're not familiar already, and help us as a state get to that place where we're looking at some paradigm shift away from old thinking around this and recognizing the wave of behavioral health issues that are already coming, including the opioid epidemic and just the mental health and trauma from the last 2 or 3 years of the pandemic. But yes, sir.
You had mentioned that there doesn't seem to be much of an appetite, taken at the state level, for Medicaid expansion. Is that across party lines, or is that a north-south regional difference, or is it party affiliation?
It's along party lines, and it's the Republican Party is opposed almost universally to this concept. Even those legislators that agree in concept with the idea of doing this, they more or less dismiss me and say, that's never going to pass. You can talk about it if you want to, but there's no way. It's a dead issue. And I can't get a forum where I can have an intelligent discussion about it, because I think their constituents are just not going. It's become a buzzword almost that their constituents just will not listen to, and they see it as giving more money to a broken system and giving more money to people that don't deserve it. And that's quite frankly the attitude. And I can't seem to make an inroad there where I say it's not about that. It's about, and look at the other states, right? There's 42 or 3 other states, maybe not that many, 40 other states that have done this, and you have the data. You have the data to show that providing this kind of health care lowers your health care costs and improves health outcomes, makes communities economically more stable, et cetera. The data's right there, right? JAMA, the Journal of American Medical Association, has written articles about it. Other trustworthy sources have written extensive articles about it. It's not just me talking, it's really the data that indicates this has a positive impact. There'll be people maybe that don't deserve, if that's your definition of this kind of help, but for the vast majority, you have to look at population health, and you look at the vast majority of people benefit, or the communities benefit, economically and in health metrics. Yes, sir.
Yeah, sorry, I just wanted to mention that we try to wait, great question on that, but we'll leave the questions till the end, we'll have a little more chance.
Okay.
But
And-
I didn't say that I was supposed to say.
I'm sorry, yeah.
That was actually a great question.
Yes. And I want to be quiet because I know Shar has a lot of good information, and I don't want to take up all your time. So.
Thank you. So first, I want to acknowledge that September is Suicide Awareness and Prevention Month, and you have goodies on your table. There are some pins, there's some pins and pens, and there's some stickers. In behavioral health, suicide awareness and prevention is every single day, every single hour that we work. So one of my other jobs besides deputy director is I'm also the behavioral health administrator, and I supervise the crisis team. So with what Bob had mentioned, all of the strikes against us, we have some pretty awesome things happening in this county, and I want to highlight them and make sure you all know we have a very robust crisis program. Much of what Bob just said really will support what I'm saying and why we do things and how and why we do things. We are not Minnesota, and we get that all the time. We have providers that come from Minnesota that expect that a psychiatrist can just say, nope, whisk them away to the hospital, and that's not the way that it happens in Wisconsin. And in part, it's because we have a statute that says we have to do things a certain way. So we have federal guidelines that inform us on best practice. We have statute that says this is the way you're going to do it. And then we're given some limited funding on how to figure it out. So in St. Croix County, we have 3 different systems which somebody can access crisis. So we have, St. Croix County has, we are kind of the holder because we're the county. We are required to provide these 24/7 services to our residents. And we partner with Northwest Connections, and we also partner with health partners. So within St. Croix County, we actually have a crisis network where the 3 of us work together. And sometimes it's confusing and sometimes it's messy, but most of the time it works really well. All right, you can go to the next one. So in St. Croix County, we have 3 behavioral health techs. We have 2 co-responders, which I'm going to go into a little bit more in depth because that's one of the really creative ways that we have tapped into actually partnering with law enforcement and trying to help their crisis of the time that they're spending on these cases. And then we have 2 social workers after a crisis happens who follow up with each individual to get them connected to services. Northwest Connections is our provider that provides the 24/7. So we have to have somebody available at all times. So Monday through Friday, 8 to 4:30, we have somebody within our services center in New Richmond available for anyone to walk in and we can provide them service. However, at 431, we don't always have somebody available. So Northwest Connections is primarily, they provide a phone crisis response. Northwest Connections, I think they serve 30 counties, and they have 2 separate phone, they serve they cut the state in half, and so they're very busy. They also have within our county, they provide mobile, so if the phone assessment doesn't work and they need somebody to do a face-to-face, we contract with them to provide somebody to go on those times that we're not available, do a mobile crisis assessment. The third one I have listed up here is Health Partners. So Health Partners has created actually a really unique way of providing a crisis mental health assessment, which is a little bit different than what the other 2 are doing. It's the same under the same statute, under the same administrative rule, but they can do it within the emergency room. So many clients actually prefer that. It's void of law enforcement. Somebody can go into any emergency room within the Health Partner system, Baldwin and River Falls, and receive a telehealth assessment with a licensed mental health therapist. So that is really the difference between the Health Partners system. They can do it all through their hospital. One of the other differences is Health Partners can bill your private insurance. The crisis system within Wisconsin isn't set up, first of all, our Blue Cross Blue Shield won't cover a crisis event. They'll cover the hospitalization, but they're not going to cover somebody showing up and the equivalent of the ambulance showing up to a car. That goes to that parity piece that Bob was talking about. It's something that isn't seen, or isn't recognized as an intervention that is billable by private insurance. And as Bob said, the billing piece, people who receive crisis service, they are billed for their service. Most of the time, somebody who has medical assistance, it's covered 100%. For anyone who has private insurance, it probably isn't going to be covered. So that's, again, that parity piece. It's seen very differently in the eyes of our insurance companies. All right. So very quickly, I'm not going to spend a ton of time on this. I'm going to talk about what kind of drives the bus on if you want to go to 8. So we have, so the federal guidelines, they give us, I don't know how many pieces of paper in here, maybe 90 pieces of paper. This is like our best practice. This is what you should be doing. The state gives us probably, how many? 74 pieces of paper that says, this is another, in Wisconsin, this is how you have to do it. And then we have the Health and Human Services gives us just, 4 or 5 pages, which makes more sense, and it's something that becomes a little bit easier to navigate with at the county system. So every crisis program has to be compliant with the DHS 34 administrative rules. So it really kind of dictates the who and the how and the when and how we respond to an assessment. Anybody who receives an assessment then, you can go to the next, will have a response plan. So, and I'll just show you in a couple slides. It just shows you what it looks like. It's a triplicate form. So you show up and the social worker is meeting with you and the family or your supports, and 90% of the time to 90 to 95% of the time, it isn't a hospitalization. It's something, it's a community plan with your family, with the supports you need, connecting you to resources. And there's a triplicate form, it's written out, everybody agrees, the client is part of the plan, and we have the social worker follow up the next day. It's the time that what Sheriff Knutson was talking about is when it rises to the level where there is, it met that threshold. So they have to be, so there's the crisis thresholds are that the client has to demonstrate behaviors that could be a mental illness. I mean, nobody's diagnosing, but it looks like it could be a mental illness. And that there's a substantial probability of physical harm to self or others evident by a recent, so this is also another piece that we get stuck on, act, omission, attempt, or threat. And that person is not willing to go voluntarily. So there is a really high threshold for somebody to meet that criteria. I want to say that our law enforcement in this county are amazing. They do amazing work. They are. They go over and above. They do not want to see people going to Winnebago. Neither do we. Winnebago costs the county $1,300 a day. We don't want people there. It's an institution, and it has a purpose. It definitely has a purpose, and then we definitely need it. But we don't want to just be sending people willy-nilly to that institution. All right. So just really quickly, the collaboration between law enforcement and crisis. So in this county and in the state of Wisconsin, law enforcement has to be part of this decision to make that taking somebody into custody and doing that emergency detention. So law enforcement they are also in our county on the hook for testifying to, was there danger, all those things I talked about, the and and the and and the and. Is there dangerousness? Is it likely due to mental illness? And are they not willing to go? So it isn't taken lightly. It's something that they really have to work through. The crisis person works in collaboration with them. If that's determined, that crisis person now is looking for the most appropriate, least restrictive, most appropriate placement for that person. All right. So this is our last year's crisis response. So generally, looking back, probably the last 5 years, we've had over 1,000 calls. This last year, I have this chart and then I have another chart that just kind of shows, last year we had less calls, but we had about the same amount of people that went to voluntary and involuntary hospitalizations. Some of the thought is that, you can go to the next slide. Some of the thought is that it was because that the 988 rolled out and there was a nationwide campaign for people to contact 988. And 988 went from, because it used to be the Suicide Hotline, and it was the same system, but they remarketed it and made it bigger, and they were inundated with calls. So it has been very successful in that sense. And this is a trend, not just us seeing, I will take less crisis calls any day. But it's not just a trend with us, it's the trend all through Wisconsin. Okay, so this is a map. It's probably really small and you can't see it very well. But just to give you a perspective of what's available, when the sheriff tells you that nothing's available, there are very few hospitals available. So for adults, and I just picked the services center because it's kind of in the middle of the county, but to go to Amory Behavioral Health is one of the ones we use a lot. It's a 10-bed facility. It used to be just geriatric. It switched over probably about 5 years ago. So they take, it has to be an adult for mental health, voluntary or involuntarily. So part of the piece of Amory is it's not connected to the hospital. It's actually across from our Savior's Lutheran Church. It's used to be the library. Actually, it used to be the hospital, because I was born there a long time ago. So it's a place that can facilitate everything that's necessary. It's close to our community. It's close to the family members and support systems. And if we can use Amory, honestly, that's ideal, right? Because they're very, very close. In an involuntary, the transportation must be done by law enforcement. So these are the distance when the sheriff was talking, these are the distance, and think of how much time that takes. Round trip to Amory is 44 miles. Round trip to Sacred Heart or Mayo is about 130 miles. And then Winnebago is our next closest that we would be able to access. There's also Gunderson and La Crosse, but that's pretty far away too. 514 miles. So that's a long way. For juveniles, it's even more scarce. So we do have Sacred Heart Hospital will take kids over 12 or over. Not a lot of the hospitals will. So the options are very limited for kids that need to be placed in on a secure detention hold. So we have Sacred Heart, Gunderson, and La Crosse, and then we have Winnebago. So just going back to, so if it doesn't happen to be it's not one of the 5 or 10% that end up in a hospital, what else happens? So part of our DHS 34 rules is that we have to have a response plan, and the response plan has to be communicated with the client, has to be created with the client. They have to be in agreement with it. So there's several things that we can do, and we can be creative. And sometimes this is the best, we always have to look at the least restrictive, most appropriate situation. So it might be a family friend, it might be grandma and grandpa, it might be the neighbor, but finding somewhere that for that person to be safe for at least the night, if not longer, and knowing that someone from the county will be calling the next business day to offer services and get you connected to whatever it is you need. So it can be anything from, if somebody, this is something too, if there's anyone that has a tendency for crisis or has been going through a rough time, we always have a crisis plan we have a portal that is accessible by all 3 of those entities that I talked about, Northwest, us, and the hospital. And so if somebody's in crisis, they initially check to see, does somebody have a crisis plan? Because it gives them autonomy. It gives somebody autonomy in creating their own plan. So if, they're going through a rough time, they can say, these are the things that are gonna work for me. These are the things that I really wanna tap into. And we can pull that and work off of that. And we're not trying to make things up on the fly. Really just getting people connected with services. Sometimes it's the basic pieces of life that people don't have access to. Housing is such a crisis in our affordable housing is a crisis in our area. And information and referral, all sorts of things. But there's a triplicate form. It looks like this, and we just rip it apart and give it to the person, and then we're done with the crisis event, and then we follow up that next day. All right, and very quickly, that linkage and follow up. They're calling, checking to see what resources they need, what they want. We have through some ARPA funding that I'm going to talk about with our co-responders, we were able to hire 2 community case managers, and they do a lot of the follow-up. So they can actually go out to your house and help you fill out your Medicaid form if that's what you need, or housing applications, or help with job search, or whatever it is. Some of those essential functions of life that we don't always, that create crisis in people's lives. All right, so the co-responders. So we have, the American Rescue Plan Act allowed us $2.7 million we were allotted in health, 2.1 in Health and Human Services. Our board was incredibly gracious and allowed us to pursue some things that for clients who were unduly affected by the pandemic. So those with really that mental health, the world of mental health, housing, homelessness, justice-involved folks. So we really tried to figure out how could we create a system to help them kind of even the playing field from that pandemic and get them to a place where they're feeling a little bit more stable. So we were able to hire, like I just said, two case managers that work in the community, one that works in the justice in the government center, because as you know, we're like 22 miles away from you, right? So we're in Richmond, and if you don't have transportation, you might as well be on the moon, because it's not doable to get there to sign up for services. So we have one that is in the government center that works, specifically works with justice-involved folks who need to, either they're required to or they're wanting to get connected to services. And then we have these 2 co-responders. So the co-responders, the reason that we looked at this model was because law enforcement at that time especially was in dire straits with they didn't have enough employees even to do what they needed to do, right? They were short-staffed and desperate in that. So we saw this model, and it's kind of a hybrid co-responder model that a true co-responder model, there would be one officer and one social worker, and they would work together all the time. Because we have so many jurisdictions, we have memorandums of understanding with all of our law enforcement jurisdictions, so they all have access to them. We have 2 of them, and they work staggered hours. So on any given, they work Monday through Friday about 11 a.m. to 10 p.m. And they carry radios, police radios. So they've been trained in police radio. They have push notifications on their phones. So law enforcement has the ability, instead of going through Northwest or through the county or to telehealth, they can just call them on the radio, and the law enforcement, if they're going to a mental health welfare check or something that they know that they're going to need them, they call them right away. They hop in a county fleet car. They don't ride with law enforcement, because once they get there and the scene is safe, they can leave. Law enforcement can just leave the scene. So it was intentionally built like that because of our needs are maybe a little bit different than the needs of that, having that model with the one officer and the one worker. So we serve all of the county. By far, the sheriff's office utilizes them the most because they cover more of the area and they're working the hours that some of the smaller law enforcement agencies don't have hours to cover. And kind of just looking at what is a co-responder. So they've been questioned a lot as to what their role is. And really their role is to provide that immediate, instead of calling you the next day and setting you up with resources, they can do it on the spot. They can say, what do you need? If I can get you an appointment, we'll do that right now. If it's after hours, we'll get you connected. And they can walk the family through, or the person through the crisis at that time. They're also able to, like I said, give law enforcement some of their time back. One of the benefits is they've been two stable faces that the same law enforcement are working. So they're really building relationships and team, and they work really well together. They don't always agree, and that's okay, but there's also an opportunity for discussion and dialogue, and to really talk things through. So when there is an emergency detention, I can guarantee you that there was a lot of dialogue as to, do we meet these standards? So they are just such a benefit for us. That one of the things that they are not is they are not law enforcement. They show up on scene with, actually they have shirts like this that says co-responder on the bottom. So they're identifiable on scene, but they don't have any law enforcement other than the radio. The radio serves as a purpose for safety for them as well. So if law enforcement leaves, they can call them back. And that has happened on a couple occasions where it seemed like it was fine and things escalated quickly and they came back on scene. I can tell you also that they don't go very far when they usually they're somewhere in the neighborhood. They're not crisis negotiators, that, they haven't been trained. And they are not licensed therapists. They're bachelor level staff who are trained in crisis stuff. And where can they go? Everywhere. They have been on the roadside. They've been in a field. They've been at schools. They go wherever law enforcement is, and they just go meet them and deal with the crisis where it's at. So one of the things I did want to do is I want to do a little bit of a commercial for behavioral health or health and human services in general. There's so many staff, and I didn't know either when I started, but so many staff that have started and they said, wow, I had no idea you did all these things. So in behavioral health, we kind of broke it down to 3 different areas. We have community-based services, we have crisis services that I just talked about at length, and we have clinic services. So we have probably one of the coolest things that we offer is the Comprehensive Community Support Program, it's CCS, if you've heard it. It's one of the downsides, it's only billable to Medicaid. So if you don't have Medicaid, it's a service that is not currently available to others, but they can do, because especially with kids, talk therapy doesn't work for everybody. It's not for everybody, and if it's the only option, some people might opt not to get involved in services. They are able to create a plan with out-of-the-box type interventions like yoga or boxing or equine therapy, whatever that person needs to be able to work through their trauma or as their therapy. And that's for children and adults, and it is bigger than it has ever been. How many? Like 140, which is, it's probably triple from 3 years ago when I started. Yeah. The other is we have the Community Support Program, which CSP, which we love our acronyms, and they're all so close. So that is really for those who have chronic mental illness, who really need that longer-term support within the community. Sometimes those in CSP might need a higher level of care, so they can go to the group home, maybe they go back to their living environment, but it allows people the autonomy to live at that least restrictive placement and with the supports that they need, as long as they can. In our clinic, we just are newly licensed as an integrated clinic, so we have the ability to have substance use, mental health, but also have an integrated therapist that can do both. So it's really the ideal. So you have a one-stop shop. It puts all of our mental health and substance use services under one roof, which makes for better care for everybody. We also have a psychiatrist. We have one that's 2.5 days a week. We have him in-house. We have another psychiatrist 2.5 days a month, telehealth. And then we have a psychologist who does testing, and we have a behavioral health nurse within our clinic. The other thing I have on the table, I brought all sorts of resources. Please take one, share it, and make sure you get your stickers and your pen and your pin for suicide awareness. And that's all I have.